This has already been described. This optic disc pit causes maculopathy and so causes decrease in vision. Prevalence is already given. 20 to 25%, 25 to 75% causes visually debilitating complication like maculopathy. And one of the important treatment is pulmonary vitrectomy with PVD induction is an effective option, but other option has been tried. So these are the various modality of treatment which has been there in optic disc maculopathy. So there are limited studies showing functional anatomic outcome following surgery for optic disc maculopathy. So we have studied the surgical outcome, anatomical surgical outcomes of PPV with various techniques. Primary object improvement is best corrective visual acuity. Secondary improvement anatomical outcomes of OCT. And inclusion criteria: these present optic maculopathy, visual acuity less than 618, patient willing for surgery, and patient willing for follow-up also. And these are the two we have divided into. One is PPV alone, the PVD induction is there, and another stuffing of the island, stuffing of the optic disc pit with various things. Like in the second group, stuffing optic with various material, interlimiting membrane, and two is scleral tissue. We have also used the glue but unsuccessful. This is the video of one of the case. क्या गया वीडियो चलाना नहीं चलेगा ये कहाँ पे जाना देखना डबल क्लिक करना एक हाँ ओके ओके करना VLCP दूसरा डाउनलोड यहीं से डेस्कटॉप पे initially PVD induction is done and vitrectomy is done, and after that this is the case where we have done this scleral plug. We have taken from the scleral tissue from the patient, and the thing is saved off, and it has been 1 to 2 millimeter, and in the forceps we have inserted, and we have put over the disc, and we just stuffed up optic disc pit with this scleral tissue. As you can see, initially we were very reluctant because it may cause optic nerve damage, but with successful using of other techniques we have tried to fill it this, because one of the important source of fluid is the optic bit from the CSF subretinal space. So as I have already told you, there are two methods: vitreous, the cause of maculopathy, vitreous factor, which can be relieved with pulmonary vitrectomy with PVD induction, and another is closure of the hole, because the hole is pit is the source of the thing. बंद करना कहाँ से होगा स्लाइड So this is one of the case where there is a macular CSS, there is a fluid in the all the layers in the NST. This patient has a vision of 612, and we have operated because patient was complaining of metamorphopsia, and after 1 year there is a resolution. This is a case where we have done only PPV with PVD induction only. So we have 10 cases. As you can see, visual acuity improve over the 1 month, 3 month, 6 month in the both the cases, and CMT reduction also been done. And SRF height is also decreased by initially 1 to 2 months, but it takes up to 1 year in the complete resolution of the SRF extent. So this is another case where we have done just observation. This just to show you, if there is only macular CSS, if there is no NSD, then we should not operate, because there is no complaint. This is an incidental finding which was detected. This is another case where we have patient presented with 6 by 60 vision, and in this case we have put a scler grafting in the pit, and there is a resolution, not complete resolution. This is 2 months old. There is a no complete resolution of the fluid still there, but there is a visual improvement is remarkable, 6 by 24. It depends on when the patient present. If patient present earlier, the visual recovery is good, but majority of the patient present late, so the visual outcome is not that much. So mean logMAR visual improved from 1 to 0.5, and there was significant decrease in the CMT, SRF height. So surgical intervention significantly improved both anatomical and functional outcome of this pit in both the groups. So PPV with removal of traction is beneficial in improving the visual outcome of some patients with optic maculopathy, but only in 50 to 60%. Another percentage of cases, the stuffing of scleral tissue or the stuffing of the optic disc pit with the either ILM or with scleral tissue or amniotic membrane maybe cause earlier resolution and improvement in the vision. Thank you.
What would be your approach if the vision is good and the patient is having an optic disc pit? Would you still go for
because in only in one study this spontaneous resolution is there, and 75% where there is a progression of the disease, till NSD is there, patient also doesn't complain. So in one case where 4 years I am following, the maculosis is there, but there is no NSD. When NSD start, patient having a subtle metamorphopsia. So that is the time we can take. But the thing is, the long duration progression, this progress very slowly. If we don't operate, ultimately their vision decreases, because we have a patient of optic disc pit with vision finger counting or 6 by 60. With last patient was vision by 6 by 60, 1 year, only 3 month history. I think he's an educated CBI person. So there we have put scleral plug, and there the 100% resolution within a 1 month. Other cases takes time, over 1 month, 2 months, up to a year. But if you plug the pit, then resolution is faster. That's the thing.
My question to the panel was, would you advocate lasers in the early stages? Because there used to be a discussion a while back regarding the laser
I think there was not even now, even earlier, 15 years ago, we were doing laser, light laser burns. Yes, you may think it's not right, but we've done it. Would just keep 2 burn gap apart, not confluent, but would put at least 2 to 3 rows. We did that with sometimes with or without C3R F8 actually. We used to do that, but we realized that most of the patients, the fluid will come back after 2 months, 3 months and 6 months. So each one, as you grow and you will see your techniques you would run. So in my hands or in my clinical understanding, lasers have not worked for me.
Here the 2 ways of pathogenesis, whether fluid is from vitreous or from the CSF. So unless we don't know which patient will respond with what. That is why earlier we used to PPV vitrectomy, but fluid absorption is supposed to be delayed. But this is where we have done 8 case scleral plug in which 2 has been displaced. So there the resolution is very fast. Now the days is people are putting more and more confidence we are getting, putting the ILM or the amniotic membrane plug. So result, this is within 1 month the fluid has decreased. Thank you.
Sir, in my clinical experience, I have done ILM. I usually will stuff it with ILM because I find it, ILM works fairly easy in my hands.
If you can stuff with confidence, if it doesn't displace next day, initially you may be doing lot of these things where stuffing. The prevalence of this disease is very less, so very less.